So good evening, our dear viewers. This clinical and intervention nights at CEC on Thursdays. Tonight we are discussing, as usual in December, we decided to discuss the updates in the top 2020 trials. We discussed in the two previous sessions the top 2020 trials regarding the clinical and pharmacotherapy. And tonight we'll be discussing the update in the coronary interventions trials. This is the first part one. This is a very big session. We will be discussing four very interesting trials. The Prospect Absorb trial, which was a randomized evaluation of stenting the vulnerable plaque, which is not significant but is vulnerable, as we would see. The ultimate trial, the 3 years update. The ultimate trial was published in 2018, and this is the 3 years update for the IVUS versus non-IVUS or without coronary imaging or routine angiographically based drug-eluting stenting. The Disrupt CAD 3 trial, which is the trial demonstrating the safety and the efficacy of the intravascular lithotripsy, the shockwave balloon device for treatment of severely calcified coronary artery disease, and the debate of bifurcations, 2-stent versus 1-stent technique or provisional stenting in the definition 2 trial with a new definition of complex coronary bifurcation. So hopefully this will be a very interesting session actually. I will be having moderating with me today or tonight actually my dear friends, Professor Karim Mahmoud from Cairo University and Professor Haitham Suleiman from Fayoum University. Both of them will be following your questions also on YouTube channel, and also feel free to interact whenever needed. So let's move, and I will start a little bit with something easy, which is the ultimate trial. This is the ultimate at 2018, as you know. It was a trial involving 1,450 patients, and it aimed at determining the benefits of the IVUS guidance over the routine angiographically guided PCI in all comer patients. So all comer patients except STEMIs, even STEMIs after 24 hours were included, but CTOs were excluded actually. So it included all stable angina patients, all acute coronary syndrome patients, and MI within the past 24 hours was excluded. So all of the comers were divided into two groups: IVUS guided DES implantation versus angiographically guided DES implantation. And the endpoint was the target vessel failure at 12 months, which was the component of cardiac death, target vessel MI, and revascularization at 12 months, clinically driven revascularization at 12 months. So nearly 724 patients were included in every group, and those were the results of the 1-year ultimate trial. 2.9% of the target vessel failure at 12 months in the IVUS group, and this was nearly doubled in the angiography group. And the secondary outcome was the target lesion revascularization, clinically driven, or definitely.
Dr. Muhammad, I'm terribly sorry for the interruption, but can you share your screen, please?
It's not shared?
No.
Okay. Can you see it now?
It's loading, yes. Now we can see it.
So this was the ultimate trial in 2018, as we said. It was designed over 1,450 patients to angiographically guided PCI versus IVUS guided PCI, and the primary endpoint was the target vessel failure, which is the cardiac death MI, and target vessel revascularization, which is clinically driven at 12 months, and this trial was published in 2018. The primary outcome occurred in nearly 3% of the IVUS group versus 5.5% in the angiography group. and 0.9% was the secondary outcome, which was the clinically driven target lesion revascularization or definitive stent thrombosis, 1% in the IVUS versus 2.3 in the angiography group. And hence we got here the definition or the idea that this was the summary that, as you see, among all comers undergoing PCI, the IVUS guided PCI was associated with a lower frequency of target vessel failure at 12 months compared with angiographically guided PCI. The benefit was nearly doubled, as you see here. So those were the results in 2018, and now we got actually the 3 years update of this. So I will start sharing the slides for today. This is the 3 years outcome. As we said, of course, this was the first trial in 2018, and it shows a fewer 1-year target vessel failure with the IVUS guided group versus those with angiographically guided group. Included patients for all comers, silent ischemia, stable angina, unstable angina, acute MI beyond 24 hours, any de novo lesion. Exclusions were only if the patient has a low life expectancy, less than 12 months, or intolerant to death, or CTO, which is not recanalized, or severe calcification that needs root ablation. The IVUS defined criteria for the optimum stent deployment means obtaining a surface area in the cross-sectional area in the stented segment more than 5 millimeters square, or at least achieving 90% of the distal reference lumen cross-sectional area. And the plaque burden at 5 millimeters proximal or distal to the stent edge to be less than 50%, and no edge dissection within 3 millimeters of both sides. So if you achieve this, this is called an IVUS-defined optimum stent deployment. Of course, as we said, 724 patients in each side, and we achieved a follow-up of 98.6% in the IVUS group and 98% in the angiography group, which is an excellent follow-up at 3 years. The baseline clinical data were equal. The core lab decision data was also equal between both groups. Nothing was significant. The procedural data in the IVUS guidance, the mean stent diameter deployed was 3.15, and angiographically guided was 2.99, and this is significant. The maximum balloon diameter was 3.84 in the IVUS versus 3.62 in the angiography, and this was significant. And the maximum post-dilatation pressure was nearly 20 in the IVUS versus 19 in the angiography, which was also significant. And here maybe I can stand just one moment to show you that IVUS made us increase the size of the stent by nearly 0.25 millimeter, quarter of millimeter, and we increased the diameter of the balloon by also quarter of millimeter, and we increased the pressure of dilatation up to 20. So maybe if you don't have an IVUS and you want to oversize the vessel, so maybe if it's 2.75, you can choose a 3 millimeter stent, and you can inflate the balloon at a higher pressure with a non-compliant balloon, and maybe you will achieve results which would be more or less comparable to the IVUS. Of course, this was on the expense of the time. It was 15 minutes more with the IVUS, 60 minutes compared to 45 minutes only with the angiography, and with more of 20 milliliters contrast volume, 178 with the IVUS versus 161 with the angiography. So the expense was in the form of more time and more contrast volume, and of course, more cost. And as you can see here, I will show you now the 3-year clinical follow-up. So at first, this one was 2.9, this one was 5.4. The target vessel failure increased after 3 years from 5.4 to 10.7, and from 2.9 to 6.6. So both of the events of target vessel failure were doubled at 3 years, but still maintaining a significant difference between the angiography guided intervention and the IVUS guided intervention, which is actually nearly double and very significant. And this is here I want to show you the curve of obtaining what we know as optimal versus suboptimal IVUS-based intervention. If you see here, the optimal PCI maintained by IVUS is the one with the yellow lines, which are interrupted here. And this, the target vessel failure at 3 years was only 4.2%. And what I told you previously about using a bigger balloon and using a higher pressure, it improved the outcomes from 10.7 to 9.2. So what you say is optimal by angiography versus what is really optimal by IVUS, as I told you, is also showing the patient double a benefit. So actually, you need to achieve with the IVUS the 3 points that we said previously here about obtaining what is known as an optimal deployment, obtaining a minimal cross-sectional area of more than 5 millimeters square, plaque burden at the 5 millimeter proximal or distal to be less than 50%, and no edge dissection within 3 millimeters. And this is the 3-year follow-up as you see here. The cardiac death was not significant, but the target vessel MI and the clinically driven target vessel revascularization both were significantly higher in the angiography guided group versus the IVUS guided group. And this was maintained benefit in all the subgroups, as you saw here, whether the age, whether the sex, diabetes, whether it's an acute coronary syndrome, whether the patient has chronic kidney disease, single or multi-vessel, whatsoever, the benefit was maintained in the IVUS versus the angiographically guided intervention. So at 3 years, the results are maintained. IVUS is nearly double as better as usual angiographically guided intervention regarding the target vessel failure. So I will stop here. Maybe we have some discussion with Karim, Haitham, and Ahmed Saeed, and then I will move to the next track.
Thank you, Mohammed, for this elegant demonstration of the ultimate trial. I think we all know now that IVUS is very important in PCI, and if we have the facility and the availability to use the IVUS, we should use it. Of course, the financial constraint forbid the use of IVUS in many cases. However, if we have an access to the IVUS, we should use it. IVUS will help not only to optimize the immediate outcome, but as you mentioned, the 3-year outcome is much improved with the use of IVUS due to obtaining a very good result and obtaining a minimal luminal cross-section area more than 5, as you mentioned. I'd like to ask you about the stent malapposition and the stent apposition and the malapposition is not reported in the criteria of IVUS optimal stent deployment. What do you think about that?
Yes, because as you saw, that you're obtaining a minimal lumen cross area of 5 or 90% of the distal reference with achieving a post-balloon dilatation at 20 atmosphere, which is usually 0.25 millimeters square higher than the vessel diameter. So definitely you will not get any malapposition if you submit to those rules.
So it's a method for making it
optimal IVUS intervention.
Yes.
Mohammed, it was a little bit strange that the contrast, the amount of contrast was increased with the use of IVUS. You know that there was some trials that tried to decrease the contrast, or even not using any contrast, depending on the IVUS images of the coronary arteries.
Yes.
It's a little bit strange.
Remark. This is a very nice remark, Haytham. Actually, this concept, as you know, that this trial was started in 2016 and it was finished in 2018 and published. So at that time, we did not have that trend of using the IVUS or using zero contrast PCI, as the operators would like to say. Especially this is famous between the CTO operators because you use a lot of contrast and you can use the IVUS to identify the proximal cap, and you can use the IVUS also to identify the length of the stent that you need to deploy after dilating or after performing your ADR technique in the CTO, and knowing where the dissection starts and where the dissection ends and where the disease starts and where the disease ends. But overall, this did not include, as you saw, the CTO patients. So this included the regular patients only, and at that time, performing the PCI with a zero contrast was not yet a famous trend. So this was performed like the regular PCI that we do every day, and definitely they used more contrast, at least to identify the position and everything, and also maybe for flushing of the IVUS probe to obtain a better image, or obtaining more 1 or 2 injections after performing with IVUS pre-dilatation, post-dilatation, and so on. Because probably IVUS increased 1 or more steps at least to choose a bigger balloon and perform a better dilatation.
So you're expecting, as the learning curve is increased, and we know the tips and tricks about using the IVUS and the preparation before entering the probe of the IVUS, that this entity of increasing contrast amount and increasing the incidence of contrast-induced nephropathy in the IVUS limb will decrease eventually.
Most probably, yes.
Okay.
Most probably, yes.
A comment and a question, Mohammed. The comment with when you use IVUS in your daily practice, you will tend to increase the stent diameter implanted in most of your cases. Do you agree?
Yes.
Yes. And the question about the target vessel failure is defined as cardiac death, target vessel MI, or clinically driven target vessel revascularization.
Yes.
Do we have a data regarding each component of the primary outcome?
Yes. As you see here, the cardiac death was not significant between both groups. What was significant was the target vessel MI, which is nearly double in the angiographically guided versus the IVUS guided, and the clinically driven target vessel revascularization, which was nearly 1.5x in the angiographically guided versus the IVUS guided.
Okay. I think this is logic, because if you fail to achieve a good position of your stent, you will have a more stent thrombosis and target vessel MI, and you will go into more revascularization for your stent.
Yes. And if you not perform a proper stent apposition or proper stent sizing, which would be helped so much by using IVUS, you may get a stent thrombosis or a target vessel MI.
So
yes,
if we don't have any more question, let's go to the second trial.
Let's go to an interesting one. This one, the Disrupt CAD3 study. This was the intravascular lithotripsy for the treatment of severely calcified coronary artery disease. And this study was including the shockwave balloon. So as you know that the coronary calcium negatively impacts your PCI procedure, It can impair your device crossing. You may be not able to pass your stent. It may cause stent delamination. The stent is deformed and improperly apposed. The stent can be underexpanded, as you see, because of the calcium here in the OCT behind the stent, limiting strut expansion. The balloon actually can have insufficient force, what we know as dog boning effect of the balloon. And the options that we have include the rotablation with atherectomy also and wire bias, and of course laser, which is not available in our country, but with the devastating complication of sometimes overheating the vessel leading to coronary perforation. So the idea came from the shockwave device. The shockwave device emits acoustic pressure waves at 1 pulse per second, and those travel through the soft tissue with an effective pressure of 50 atmospheres. So this is as if you are making an indeflator at 50 atmospheres, and it fractures both the superficial and the deep calcium. So this is essentially a balloon, and this balloon has 4 electrodes upon the balloon. Once you press the button here, 3000 kilovolts of electricity pass every second through those electrodes. The electrodes inside the middle of the balloon are surrounded by the saline and the contrast that are used to fill the balloon, because your balloon is inflated at a pressure of 4. So once you inflate the balloon at the pressure of 4, the balloon will have the central electrode in the middle, and this will be surrounded by saline and contrast. Once the electricity hits this saline and contrast, it generates vapor particles within the saline and the contrast. And those vapor particles transmit the shock waves at the pressure of 50 atmospheres to the surrounding vessel wall. The soft tissue usually is not affected by those waves. The hard tissue, which is the calcium, is the one that is most affected by those waves. And you can repeat the shock waves as necessary by pressing this button, and those waves will be delivered on second by second waves, as I explained previously. So this is an example. This is a coronary artery, and this is the OCT catheter, and here you have the shock wave balloon. The lumen area was 1.69, and as you see, this is a complete 360-degree arc of calcium here. After you performed the intravascular lithotripsy, the calcium was fractured as you saw here, and the complete arc is now an incomplete arc divided into nearly 4 segments of calcium. And then you can put your stent and inflate it, and you can achieve a lumen area of 9.5 millimeters square when you started by a 1.69 with a complete circumference of calcium. So actually the idea is very nice and the idea is very effective. And this Disrupt Cat 3 trial was very interesting in its design. It included 47 international sites, and those 47 international sites, each site of them included 1 patient roll-in population. It means that the site itself chose this particular patient to perform the procedure. And this is what we call, we call it what? The demo patient. So this is the demo patient. So every one of the 47 sites chose one of the patients. So those are the rolled-in population, 47 patients, okay? And then this is the demo patient. So you learn the technique, because the technique is actually very easy. You can learn it by only 1 patient. And then this site is eligible to be included in the intention to treat population, which was 384 patients, okay? So we include heavily calcified de novo coronary lesions. This does not include in-stent restenosis. The reference vessel diameter between 2.5 and 4, so it does not include left main. Stenosis more than 50%, of course. Lesion length less than 40 millimeters. And as I said previously, that 1 roll inpatient per site was allowed. Okay. The major endpoints or the primary endpoints, the primary safety endpoint was the freedom of MACE at 30 days. Cardiac death, cardiac MI, or target vessel revascularization at 30 days. This is the primary safety endpoint. The primary efficacy endpoint is achieving a procedural success, which is successful stent delivery with residual stenosis less than 50% and without in-hospital MACE. The secondary endpoints include all the drawbacks of calcium, the device crossing success, the angiographic success, the procedural success with residual stenosis less than 30% without in-hospital MACE, and the periprocedural MI was tested using the SCAI definition and using the fourth universal definition of your Prince's Society of Cardiology. Of course, patients were included. Biomarkers were tested, LV ejection fraction more than 25, as we said, a single de novo lesion with a lumen area between 2.5 and 4, FFR significant, stenosis significant by IVUS angiography or OCT, evidence of ischemia, vessel size between 2.5 and 4, lesion length less than 40 millimeter, and as we said, the lesion site severe calcification. Look at this, the angiographic radio opacities prior to contrast involving both sides of the arterial wall. So this is the kind of patient that on the fluoro or in the cine, you see the calcium surrounding the vessel, above the vessel and below the vessel, and you have a total calcium length of more than 15 millimeters, or at least 3/4 of a full circle, 270 degrees of calcium by IVUS or OCT. So those included actually highly calcified patients regarding the length, regarding the arc, and regarding the luminal stenosis. Of course, you excluded the patients with recent MI and the patients with renal failure. This is statistics. We don't need to discuss this, and this is the investigators and the sites. So this is the number of the patients. We have the roll-in patients, which is the demo patient, 47 patients for 47 sites. And then we have the 384 intention to treat population and 30 days follow-up for 381 of those. Baseline clinical characteristics were not significant between both. Of course, it was described here. This is the 384. We underwent a single procedure, so this is a single arm study, as you saw here. And this is the angina class. Most of the patients were class 2 and class 3 angina. Angiographic characteristics, as you saw here, that the LED was more than half of the vessel. Left main was only 1%, nearly 1 or 2 patients only with the reference diameter of less than 4 millimeter. Next was the RCA, 30%, and finally was the LCX. The reference vessel diameter was between 2.5 and 3.5, and the minimal lumen area was actually very small, 1.1. Diameter stenosis 65 plus minus 11, lesion length 26 plus minus 12, calcified length, look how long, 47.9 plus minus 18.8, and severe calcification by definition that I told you, achieving a 270 degrees, 3/4 of a full circle, and more than 15 millimeters of calcium was included in all the 384 patients. Procedure characteristics, of course, the total procedure time was nearly 1 hour. Pre-dilatation in 55% of those cases. Intravenous lithotripsy catheters, we used 1 to 2 catheters per patient, not per lesion, because sometimes you can use a catheter for more than 1 lesion within the same patient, but take care if you have a small vessel like a 2.5 and a big vessel like a 4, so most probably you will use 2 catheters in this patient. And this is the number of pulses, 70 pulses plus minus 30 pulses. This is the maximum inflation pressure. Usually we inflate it at 4 to 6 atmospheres. And this is the post dilatation in 21% of the cases. after you disrupt the calcium, you need to post-dilate this with a non-compliant balloon before you insert your stent, of course. And the numbers of stent implanted was between 1 and 2 stents. Stent delivery was succeeded in 99% of the cases, and post-stent dilatation also in 99% of the cases. And this is the angiographic outcome. So this is the diameter of stenosis, and this is the pre-procedure, as I told you, was 65%. And the post-intravascular lithotripsy, this 65% dropped half to 37%. And then after stent implantation, it dropped by another 2/3 up to 11%. So this is the minimal lumen diameter shift. So with the pre-procedure, minimal lumen diameter was 1.1, as I said. After the dilatation, it was nearly 2, and after stent implantation, it was nearly 3. So this is a very good success. And as we said regarding the complications, it was a safe procedure. The dissection, which was type D to F, which mandated a second stent, was 2% of the cases. Perforation, no. Vessel closure, no. Slow flow, 0.6%. No reflow, 0.0%. No reflow did not happen, actually. So this is the in-hospital and the 30-day MACE. The in-hospital was a secondary outcome, and this was better, of course, 7% versus 8% at 30 days. All MI 6.8 versus 7.3. Non-Q wave infarction 5.7 versus 6. This is in-hospital, and this is at 30 days. All of them were very small number of patients regarding the in-hospital MACE and at 30 days MACE. The secondary endpoint for the success, the device closure success was 96%, and geographic success was 96%, with luminal stenosis less than 30% actually, rather than the 50%. It was achieved in most of the cases less than 30%, and the procedural success 92%. The peri-procedural MI, of course, it differed between using the fourth universal definition and using the SCAI. The fourth universal definition uses the 5-fold, the SCAI uses the 10-fold rise in biomarkers. So this was 7.3 versus 2.6. And at 30 days, the event rate was 7.6 target lesion failure, 2.6 revascularization, and less than 1% stent thrombosis. So what actually rises as a point for discussion is that these shock waves can initiate some PVCs, premature ventricular contractions, and some patients may develop hypotension during those PVCs. So those were studied separately actually. PVCs happened and blood pressure dropped up to 20 millimeters mercury, but this was not sustained at all. As you see here, the sustained ventricular arrhythmias during or immediately after the intravascular lithotripsy, 0.4%, non-induced capture, so this was not happening due to the device, and this was happening due to the device 0%, and the p-value, of course, was not significant. So it did not have any clinical sequelae for this particular patient. So this shockwave balloon, the Disrupt CAT3, achieved the primary safety and efficacy endpoints and achieved the secondary endpoints also for success of the procedure. It was well-tolerated procedure, very low rate of major peri-procedure clinical and angiographic complications. The PVCs were common, but it was benign. It does not have any clinical sequelae to the patient. And this actually trial was performed for this device to be, included within the US, and that's why they included the 47 roll-in patients. So thank you. Karim, Haitham, Ahmed, Abdurrahman joined us now. If you have any discussion regarding this Disrupt CAT trial.
So thank you again, Mohammed. I think this trial was a proof of concept that proved that intravascular lithotripsy was effective in management of heavily calcified coronary arteries. One comment, we should be aware of the pitfalls of this device. It's a rather bulky device with and its profile is relatively it's not so low, so we can face difficulty during advancing this device, and you might need to use wire microcatheter, a smaller balloon, to make a some track for passing this device. This is number one. And number two, it's a very important point you have mentioned regarding the circumference of calcification. If we don't have more than 3/4 of a calcified arc, the ultrasonic wave will be transmitted maybe into non-calcified part, and the device might be ineffective in causing fracture of the calcified arc. The last comment, I believe we need to do a more clinical trial, to have a more clinical trial in the future regarding comparing this device maybe with a rotablator, to know the state of each device and the clinical impact of each device with the use in the heavily calcified lesions.
Yes, thank you, Karim. Actually, pre-dilatation, as you see here, was performed in 55% of the cases. So you need to pre-dilate before you pass this balloon. You pre-dilate maybe by 1.5 balloon or a 2 millimeter balloon. And then you insert this balloon, you inflate it at pressure between 4 and 6, and then you start delivering your shock waves. After that, you post-dilate with a non-compliant balloon at 1:1, as you see, and then after that, you put your stent and you post-dilate the stent again. So it is a little bit lengthy procedure, but it actually allows, as you see, the gain in the minimal lumen area, as we saw previously, from 1 millimeter up to 9 millimeter, as we saw previously.
One more point regarding if we see the baseline characteristics, the diameter stenosis, the mean diameter stenosis was 65%.
Yes.
Which is not so severe, and they might be a clever to choose such maybe not so severe stenosis to test the balloon in these types of lesion, rather than in the heavily calcified severely stenotic lesion. And I think this trial should be repeated with a very severe lesion, maybe, and included most of lesion to be more than 70% stenosis.
Yes, this 65% stenosis was not angiographically derived stenosis. So it was actually stenosis by IVUS and OCT, actually by OCT in particular, because OCT was mandatory in all the cases to determine the arc of calcium. So this was an OCT trial. All patients underwent OCT, so you determine the arc of calcium. And as you know, when you use OCT or when you use IVUS, some of the lesions that look angiographically significant, especially with the OCT or borderline angiographically, and you see them with the OCT and you determine the regular vessel size, actually those lesions appear to be more significant. So this this diameter stenosis was diameter stenosis based on the OCT, because OCT was performed in all the patients, as I said, to determine the arc of calcium.
Okay, thank you, Muhammad. There is 2 or 3 observations and comments. First of all is the marvelous decrease in the nori flow phenomena after deployment of the stent, which is a hassle in the calcified lesions, especially if we are using rotablation. We face a lot of nori flow due to the distal obliteration of the distal vascular bed. So I think if we go a step further as Dr. Karim said, with the really stenotic, heavily calcified lesions that makes challenge to all of us, with continuing to have no reflow phenomena. This will be the most benefit of this device. The second is the decrease in the blood pressure. And we all tend to give intravascular or intracoronary nitroglycerin after predilation of a heavily calcified lesion to elaborate more the diameter, the distal diameter or the diameter of the stent, the proper diameter of the stent. So I think this will be a tip when using a shockwave balloon, not to rush or to increase the dose of intracoronary nitroglycerin in order not to face more hypotension or shift a stable patient to a transient state of instability. What do you think?
Yes, regarding the no reflow, it was slow flow, as we said, in 0.6% of the cases. The no reflow is very common with the rotablation because the rotablation is a mechanically rotating device which actually cuts through the vessel wall. So it cuts through the endothelium, and then it starts by slicing the calcium from the wall. So you get lots of calcium debris that are moved to the microcirculation, and this causes no reflow. So this is a little bit much more common with the rotablation. And in the rotablation, you prepare the microcirculation by dilatation using nitroglycerin and nitroprusside, even if needed, before performing the rotablation, because you predict what's going to happen. But here it's slow flow rather than no reflow, and it's very small percent. Regarding the question of the hypotension was associated only with those cases that got the intravascular lithotripsy induced ventricular capture. And this is because, as I told you, that the device itself works by the idea of transforming the electric energy that it gets, the kilovolts that it gets on the electrodes inside the balloon. And those kilovolts are used to evaporate or create a gas within the balloon. This gas comes from the saline and the contrast inside the balloon. And this gas is like an explosion, but within the balloon. So this wave of motion or wave of ultrasound disrupts the calcium. They don't know particularly whether this wave of ultrasound is responsible for inducing the PVC, because this does not happen when you have a renal stone or you induce ultrasound to the renal stone, for example. Or actually, this balloon has also been used for the peripheral vascular disease for a longer time than the coronary, and it did not induce this effect. So most probably this is because of the electric current that passes through the electrodes, and those electrodes are inside the coronary arteries, which are epicardial vessels very close to the SA node. So they cause some kind of inhibition of the SA node or provocation of a ventricular extrasystole to induce the PVCs. The hypotension happens during the time of the PVCs, and once the PVCs is finished, the hypotension is resolved. So this is for only a few minutes or less than a few minutes, and it's only during the procedure and not moving forwards after the procedure.
Okay. One more privilege that I personally see in these devices is the preservation of the endothelium. The rotablation destroys completely the endothelium in order to chop the calcium beneath it.
Yes.
But in these devices, we keep the endothelium intact with its function. And I think this is better than having a raw surface without the endothelium.
Much better.
So I think, yeah, so I think this is more physiological. And if we progress the trials more for the more stenotic lesions, I think we will get more benefit.
Yes, and the
Dr.
post-op
Ahmed,
is very important.
yeah,
This
Dr. Ahmed and
hospital
Dr. Abdurrahman.
75,000 pounds in the Egyptian market.
I think this is because this is a new technology, and if we use it more, it will decrease in price eventually.
Yes.
And that it is mandatory to use IVAS or OCT while using this balloon till now to determine.
You need to have a very big arc of calcium.
Yes.
So the force is directed towards the calcium because this is a very big force. This is equivalent to 50 atmospheres of dilatation. Remember that if you dilate a balloon at 20 atmosphere, you are afraid that the balloon may rupture. A regular balloon or a non-compliant balloon. This is like dilating at 50 atmospheres. 50 atmospheres. So actually the main problem, if you do not have an arc of calcium that absorbs all this force and gets crushed like a biscuit, is that if you have a spot of calcium, this spot of calcium will not be disrupted. It will be moved like a bullet. And if the spot of calcium moves like a bullet, it will create a perforation. So for this technique to be successful, you need a very good patient selection. This technique is valid and very well now in the very elderly patients, the nonagenarians and the octogenarians in the Northern America and Europe, the 85s, the 90, the 95s patient, that they have a big arc of calcium. As you said, and as you saw, and geographically, you need to see the arc of calcium above and below the vessel wall. And when you perform an IVUS or an OCT, here you performed an OCT, you have a 270 degrees arc of calcium. That's 3/4 of a full circle. So patient selection is very important because if you choose the wrong patient, you may end up having a catastrophe.
Okay, Dr. Ahmed, Saeed, and Dr. Abdurrahman, do you have any comments?
Let's move to the next presentation. I have two more to go. One of them is, both of them will be very debatable and very nice. Let me show you this one. So this one was the prospect absorb trial, okay? I will show you the summary slide first so you will get the idea of this trial. So after you get a patient with an acute coronary syndrome, you perform a PCI to the culprit vessel. This is the routine practice, okay? The idea here is to perform an IVUS in the proximal 10 centimeters of the three major coronaries, LAD, LCX, and RCA. When you perform an IVUS, this is like a scan, okay? You're performing a scan. You will catch some atheromas, okay? So those atheromas are non-significant atheromas, okay? And then you will go with the near infrared spectroscopy known as NIRS. This NIRS can define what is known as the vulnerable plaque, which is the thin-capped fibrous atherosclerotic plaque. This thin-capped fibrous atherosclerotic cap is the vulnerable plaque that we believe pathologically creates an acute coronary syndrome. But we do not have any idea when this acute coronary syndrome will happen. So we do not have any data supporting whether we should treat the vulnerable plaque by stenting because the safety and the efficacy are questionable. You can perform a stent in a non-significant lesion, but it's a vulnerable plaque. What if you got a stent thrombosis? So the patient will die. So this is a safety endpoint. And what if your stent gets a restenosis? So this is an efficacy endpoint. So this is a nice idea. This is the idea that I was explaining. As you see here, the trial description. Following PCI of all flow-limiting lesions, the patients with residual moderate stenosis were randomized in an open-label one-to-one fashion to either PCI with the absorbed BVS or guideline-directed medical therapy, and those were the controls. Okay? And the follow-up was 25 months. I will not go through the results now. I just want you to understand the idea or the concept of this trial. This trial was presented by Professor Greg Stone, of course, in the TC month. This brief introduction tells us that the acute coronary syndrome arises from the rupture and thrombosis of the thin cap lipid-rich coronary atheroma that has a large plaque or lipid burden despite angiographically appearing mild. To scaffold or to stent this lesion can generate a new cap of new intimal hyperplasia or fibrosis. And this thickening of the fibrous cap and normalizing of the wall stress will stabilize the high-risk plaque. So this is a hypothesis. This is a hypothesis. So they sought to examine the outcomes of the PCI of non-flow limiting but vulnerable plaque in a pilot randomized trial meant to inform a pivotal study. So they have a study, of course, involving the intracoronary imaging. So the study was Prospect 2. So the Prospect 2 study included nurse near infrared spectroscopy for all the patients that performed PCI for the significant lesions. And then they identified between the prospect patients those patients to be included in the prospect BVS study or the prospect absorb study. So this is a study from a study, or this is a subgroup, but it's not a subgroup, it's a sub-study from the prospect 2 study, which includes more than 800 patients. So after successful PCI of all flow-limiting lesions in patients with acute coronary syndrome, STEMI and non-STEMI, the nurse and IVUS was performed at the proximal 10 centimeters of all the 3 coronary arteries. And then you identify the non-flow limiting stenosis, which were not intended for the PCI, of course. And those were stenosis, which were less than 70% angiographically, negative FFR or IFR, and reference vessel diameter of 2.5 to 4, and lesion length less than 50 millimeters. But the IVUS plaque burden was more than 65%. After that, you perform your nurse. And according to the nurse, you will get a definition of which plaque to be stented. I will tell you this definition later. So the qualifying lesions were randomized to be treated with an absorbed BVS plus medical therapy versus medical therapy alone, and the 3-vessel angiography and the nurse to be repeated at 2 years plus 1 month, 25 months in all the patients. So this is a very, very interesting trial and a very, very interesting idea. The primary efficacy endpoint, of course, was the IVUS-derived minimal lumen area at 25-month angiography. So you inserted the BVS in the non-significant lesion today, and you perform an angiography with an IVUS after 2 years and 1 month, and you see the minimal luminal area. This is the primary efficacy endpoint. The primary safety and the secondary safety endpoints were, of course, the target lesion failure, which is cardiac death, target vessel MI, or clinically driven TLR at 2 years. And the secondary included all the MACEs at the latest or the longest follow-up of the patient, even if after 2 years. So this is the Prospect 2 trial, which is the big trial, including all the patients performing the IVUS and the nurse. This is 900 patients. Of those patients, we chose 182 only that apply to this definition. They have more than one non-flow limiting, non-culprit lesion with 65% plaque burden by IVUS. So this is the qualifying patients, which is 182 patients. I took those 182 patients to be divided to 2 arms, half and half, absorb plus therapy versus guideline therapy alone. And I performed the angio and the 3-vessel IVUS nurse at 25 months. Okay? How much patients performed the follow-up? 2 years clinical follow-up of the patients was 99.5%. Median clinical follow-up of 4 years. 25-month angiography was performed in 92%, and IVUS follow-up in 86% of the patients. So this is actually a very, very, very good follow-up with very minimal patient loss. Baseline characteristics equal between the two groups, of course. Baseline QCA. So let's see where are those lesions localized. 30% in the LAD, 35% in the LCX, 35% in the RCA. Most of the lesions were in the mid segment, 44%, with 25 proximal and 16% distal. Reference vessel diameter 2.85, minimal lumen area 1.6, diameter stenosis 41%. So this is a non-significant lesion, angiographically and IVUS-based non-significant lesion. But when you perform the nurse, you identify that this is a vulnerable plaque, lipid-rich core, thin cap plaque. Okay? Maximum plaque burden by IVUS 74%. It has to be more than 75%, as we said. And this is the measures by the IVUS. And this is what I want to tell you the nurse finding, which is the lipid core index. The lipid core basal index within 4 millimeters. I will describe it to you. The maximum lipid core base index denotes the highest lipid content over any 4 millimeter segment in the lesion. You choose the most fatty part of the lesion, the most fatty 4 millimeter, and you identify the lipid content. The lipid content is a score between 0 and 1000. 0 represents 0%. 1000 represents 100% lipid content. So our number was 324.7, and this represents the upper quartile cut off for the lesions which were non-culprit in the prospect 2. And this is the pre-specified definition for a high-risk plaque using NIRS, near-infrared spectroscopy. Okay? So the pre-specified high-risk plaque characteristic include the maximum lipid core index more than 324.7, the plaque burden more than 65 or 70, and the minimal lumen area less than 4. So those lesions were included, and they performed a BVS, and after that they performed a 25-month IVUS, nurse, and angiography. So let me tell you this. After 25 months, at the original minimal luminal area site, at the baseline, it was 3 millimeters. After 25 months of performing the BVS, it was 7 millimeters in the BVS group, and it remained 3 millimeters in the medical therapy group. Across the entire lesion, including the 5 millimeter margin proximal and distal, it increased to 5.2 in the stented or the BVS group, and also still stops at 3 or 2.9 in the minimal lumen area group, in the non-treated group. So you get the idea here that the BVS treatment improved the situation, but the guideline medical therapy did not deteriorate the situation. The situation is actually classic here, 3.13, 3.12.9. This is a classic stationary situation. And this is the nurse follow-up. I just want to show you here in the red that the new intimal hyperplasia or the new cap was formed in the BVS group, and it has a thickness of 210 micrometer. So you got actually the rationale or the hypothesis that putting this BVS will promote the healing of the cap, and you will get a fibrous cap of 210 micrometer. So this is the nurse finding. What I want to show you also is the lipid core index. Look, 62. You remember the baseline was 273, and here is 268 in the medical therapy. So the vulnerable plaque more or less is not treated in the medical therapy. So let's see what happened regarding the outcomes. Target lesion failure at 24 months, cardiac death, MI, and clinically driven TLR. Overall 4.5 versus 4.3, non-significant. The components, target vessel MI, 3.3 in the BVS versus 1.1 in the medical therapy, because here you got a device-related thrombosis. Target lesion revascularization 3.3 versus 3.4. Randomized lesion-related MACE. Guideline medical therapy 10.7%, BVS 4.3%. Of course, you will not get a statistical significance because this is a very small number of patients. We are speaking about 90 patients in each arm. This is a study derived from another study. As I'm telling you, this is just a hypothesis generating study. You did not get any complications that make it significant between the two groups regarding the entire MACE. But you got a formation of a new cap and healing of the vessel. This is interesting. This was a patient from the study, 57 years old man with non-STEMI due to LAD stenosis, this one. He was treated successfully, stenting the LAD. They found a CX lesion and they found a right coronary lesion. The plaque burden of the CX was 83%, and the plaque burden of the RCA was 81% by IVUS, and the lipid core index at 4 millimeter was 944, and here was 459. So this patient qualifies for the study. The operator found the CX and the RCA lesions. What did the operator do? The operator performed PCI to the LED and performed PCI to the RCA. The RCA was performed by a BVS, 3.5 by 23 at 16 atmosphere, post-dilated 4 millimeter, non-compliant at 18, and the LCX was not treated. So this gentleman has 3 lesions. One of them was culprit LED treated routinely with a drug-eluting stent. He had 2 other lesions, one in the RCA and one in the LCX, which were angiographically not significant, but according to the definition of this study, were included. The operator decided to perform the RCA and did not perform the LCX. What happened next? The patient was asymptomatic for 9 months. After that, he developed angina. Repeated angiography demonstrating patent RCA, and this was the OM, remember, the CX lesion, here, absent. He got a thrombosis of the CX. After 9 months, this vulnerable plaque decided to cause an acute coronary syndrome. He got a thrombotically occluded OM branch at the site of origin of the high-risk lesion, despite being on high-dose statin therapy and dual antiplatelet therapy. So the operator decided to treat this LCX at that time conservatively. The patient remained stable with mild angina. At 25 months, the follow-up angiography was done because the RCA of this patient was included in the study. The LCX remains occluded. The RCA remains patent, actually with a scaffold area of 6.6 millimeters square and a minimal lumen area of 4.8 millimeters square. And the nurse showed neoantimal hyperplasia, a thickened neocap covering the prior fibroatheroma. This is what they were speaking about during the study. Of course, the study was not powered for clinical outcome. IVUS alone lacks sufficient resolution to detect all the causes of malapposition and scaffold, but severe cases would be identified. The mechanisms underlying the reduction in randomized lesion lipid content from baseline to 25 months after follow-up are still uncertain. What is the reason? We don't know. The median follow-up was 4 years. Even in more complex lesion, BVS resulted in lower target lesion failure and thrombosis after 3 years. Whether this BVS using the first generation BVS should be applied for the results for the second generation BVS, we don't know. For metallic DES, definitely we don't know. But we can conclude that in the present randomized clinical trial, the BVS implantation in angiographically mild non-flow limiting lesion as a healing technique with a large plaque burden and high lipid content was safe and resulted in an enlarged luminal dimension during follow-up. The favorable dose lesion regarding the MACE rate observed with BVS compared with guidelines needs a more powered and larger study to see the full outcomes in a statistically significant pattern. I will stop here because I expect a lots of interaction with this debatable study.
Thank you, Muhammad. This is a minefield trial with a lot of debates and points to be discussed. First, I noticed that the limb with the guideline medical therapy, optimal medical therapy, has a numerically higher, actually all numbers of vessel affection, of lipid content, and every risk factor. So I would expect that these numerically higher numbers, of course, we are talking about a very limited number of patients, will result in worse outcome in the patient with the medical treatment guidelines, medical therapy. But the only thing that separates the curve and even increases the MACE was the need of another revascularization and not cardiac death or MI. So I think this leaves us with a very big question, is that we did the need of cabbage or PCI. So no, the next slide. The next slide, yes. So the only point of separation here were requiring revascularization or clinical driven revascularization, either cabbage or PCI. But cardiac death, myocardial infarction were not really high comparing the two groups, despite that all the clinical or even angiographic and IVUS picture of these two groups were numerically higher or worse in the guideline-mediated therapy. So we're talking here about patients suffering from symptoms rather than from myocardial infarction or death, and this separated the two curves. One other thing is that in the example of patient that you did show, it's striking the discrepancy between the IVUS that considered the OM lesion non-significant or borderline lesion, and the angiographic picture. I think 90% of us will consider this OM a severely affected vessel rather than a borderline lesion. So it's a little bit unusual. IVUS tends to increase the incidence or overestimate the severity of the lesion compared to the conventional angiography. But in this particular patient, the contrary happened, that they consider that this is a borderline lesion that can be treated medically rather than angiography. So what do you think?
Uh, what we what we see actually as significant, as we said, because we are performing angiographically guided PCI most of the time here in Egypt. So what we see as significant, actually they don't see significant out there because they perform lots of imaging. So they performed an IVUS for this case, as you said, because all the three vessels were included in the nurse study and the proximal 10 centimeters of every single vessel involved an IVUS and a nurse. And this IVUS showed that this does not achieve the minimal luminal area of significance to perform a PCI. Otherwise, it would be excluded from the study. And it was included according to the plaque burden or the lipid core of the plaque, which was more than 70% or 65%. So it was included, and the nurse equation, the 4 millimeter maximal lipid index was included. And accordingly, this particular vessel could be randomized to the VVS or could be randomized to the medical therapy. This is one of the three different patients you are speaking about, 4 versus 7, as you said, which demanded the PCI, 4 versus 7. So here you know that this is one of those three patients as an example. So you can expect that the other two patients are also the same like this patient. Actually, this is a very few number to take a decision about three patients difference between 89 or 90 patients as a whole. And as we said, this is just hypothesis generating. This is the kind of the study that makes a brainstorming, like should we do or should we not do, can we do or can we not do this idea for this particular number of patients. But actually for me, we need at first to establish in our country performing PCI properly by intravascular imaging if it would be available and cost effective for most of the patients. And after we do that, as the first trial that I demonstrated, the ultimate trial, after that, after we would perform that, no problem, we can perform trials like this one to perform PCI for non-significant lesions, but we need to have the tools and techniques to prove that this non-significant lesion is actually a vulnerable plaque, and this vulnerable plaque will lead to a clinical event afterwards.
Thank you, Zahra.
Actually,
Yes, Abdurrahman, please.
okay. Yes, I believe
Ahmed
Ahmed
Said.
is
Ahmed, okay.
Ahmed Said.
Yeah, thank you,
Go ahead,
Zahran.
Ahmed.
Yeah, thank you, Haitham. Actually, I have just one. I like the idea of the study. The main idea is to prove that BVS in a non-significant lesion with a vulnerable plaque will reduce the acute events. If we look at this slide, Zahran, we have here the numbers in cardiac death. It's almost the same. So myocardial infarction was higher in the BVS group.
Yes.
And also the unstable angina was higher in the BVS group.
This is why,
Just
Ahmed.
then,
This is why.
yeah.
I will
So
show you
so
why.
this goes against the idea that the BVS prevents the vulnerable plaque to rupture. It
Ahmed,
causes
can you
from
see this
itself
one? No, no. I want to show you
a
this one.
stent thrombosis.
Yes, I want to show you this one. You see this
Yes.
slide? Now it's single
Yeah,
case
it's
of
only a
BVS.
single case.
No, no, no. I want to show you the
Yes, it is
details
a
of this
single
case.
case.
No, the details are very interesting. This is the single case that got the
Okay.
thrombosis, okay? This is the case that got the MI included in the statistics. Okay, Ahmed? So this one, this was the lesion, okay? Non-significant lesion angiographically, but by nurse and IVUS, they performed the PCI, okay? This is number B, is the BVS, Ahmed.
Okay.
Look what happened. The patient got a thrombus at the diagonal at the edge of the BVS. It did not include the BVS itself, and they performed the PTCA to this diagonal. So this diagonal, I don't know why actually they put the stent up to there, but because they need a definition of a 4 millimeter above and below the margin to be healthy. So they chose a very long BVS. The edge of the PVS was overlying the ostium of the diagonal branch. And this is what happened here. They got the thrombus here. So as you see, a mild to moderate LED stenosis was present. The patient was randomized to BVS. After that, the scaffold was inserted and implanted on high NC pressure. And after that, the scaffold crossed the ostium of the diagonal, which was angiographically narrowed and not treated. At 50 days, the patient presented with an acute lateral STEMI, and the angiography showed a thrombus at the origin of the jail diagonal without involving the LED scaffold. He underwent a PTCA to the diagonal branch. So those kind of studies, Ahmed, with this very small number of patients, you need to know event by event. So if you got like 2 patients here, you need to know
So
what
that
happened
was
to
the
those
only
particular 2 patients.
thrombosis. That
Yes.
was the only thrombosis, Zahran, in the study.
Yes, the only thrombosis. I will show you the slides again.
Okay.
This was the only thrombosis case. That's why I'm telling you, it's just a hypothesis generating study. You cannot take any more data apart from just thinking about the idea, and the idea is applicable, and you have numbers to tell you what are the cutoff points for choosing the lipid core, what is the cutoff point for using the nurse and everything. But
The
regarding
problem, Zahran, that this study, as you said, is a very, very small study. It generated only a hypothesis, but it also, in my opinion, opens a Pandora box about the concept.
yes,
So I think this study, before going at large or being opt to all the cardiology community, should be repeated in a more strict and much more patients before even generalizing this idea, because this is a very, very dangerous idea to show or to raise without a very hard evidence.
in a country like
This is a
Egypt,
Pandora box. Yes.
definitely. This is a very
So, but also, Zahran, there was also in the unstable angina. Also, there was one case in the BVS that was not in the guideline.
yes. This one,
The
I will
medical
show
therapy.
you. I will
Yes.
show you. I will show you. This one.
Okay.
This is the second case. This one. This one. Late acquired malapposition and intraluminal scaffold dismantling. Dismantling means that the struts of the scaffold are not attached to the vessel wall and floating inside the vessel lumen. So this is the scaffold, and this is the follow-up that was done angiography. And this follow-up showed something like a positive remodeling here. So they did the IVUS, and they found those struts floating inside. This they found what? The vessel area increased to 26.2 millimeter by positive remodeling. The minimal luminal area increased to 13.8. There were several struts in the middle body of the BVS malopposed, late acquired malapposition. The malapposition length was 1.4 millimeter and the malapposition area was 1.3 millimeter square. So PCI was not performed. The patient optimized his medical therapy and remained asymptomatic for 3.6 years because they assumed that after 3.6 or 4 years, this is past the point of complete scaffold bioabsorption and the scaffold will not be remaining there. So what I need to say also is that we have a follow-up here for those patients up to 4 years. Usually at 4 years, this angiography was performed at 25-month routine because this was the study protocol. But maybe if you perform angiography at 4 years, you will not find the scaffold at all. The scaffold will be totally dissolved, and what you will find only would be the fibrous cap, the healed fibrous cap, or what we call the new cap. So for me, I interpret this study as a very hot brainstorming study. You put the scaffold after 3 to 4 years, there's no scaffold. The scaffold promotes healing of the cap and formation of the new fibrous cap, which has been proven to be present by the nurse. And at the same time, those lesions that were not treated were actually responsible for some cases of acute coronary syndrome later during the follow-up. So this is the 2 or 3 ideas that I would conclude from such a study, but I would not extrapolate more data than this.
Can I add a final comment, please?
Yes, Karim, please.
Thank you for all your comments and for your illustration of this trial. My final conclusion, we should be cautious about interpretation of this study for many points. As you mentioned, number one is a small sized trial, so not including a large number of patients. Number two, the primary outcome is a change in the minimal luminal area, which is not clinically driven. And even when they show the clinical target vessel failure as a secondary endpoint, it was not statistically significant. Number three, the stent used was biovascular scaffold, and we all know the negative data of biovascular scaffold and inferiority to the conventional drug-eluting stents. And number four, it is the unclear mechanism of reduction of lipid core while using the biovascular scaffold. I don't understand how it would decrease the lipid core, and I think they have mentioned that in the limitation. So based on that, I'm not going to change the current practice of treating the non-flow limiting lesion, even they appear to be vulnerable plaques, by medical treatment rather than doing stenting to them.
Of course, no one would change his practice according to this, as we said, but I think to me that putting the optimal guideline-directed medical therapy, including the high-dose statins, plus putting the biovascular scaffold, including the drug on the scaffold, would promote the healing, and this would reduce the lipid core and increase the fibrous cap at the same time. And this is how we stent acute coronary syndromes with significant lesions, because the significant lesion is most probably a thrombus. And as we know that the plaque that ruptured was mostly a vulnerable but non-significant plaque. So maybe 2 hours before the non-STEMI, the patient has a non-significant plaque. But after 2 hours, he got chest pain and we did the ECG and he moved to the cath lab. We found a subtotal occlusion of the LED. This subtotal occlusion of the LED is 90% stenosis. This 90% is 20% atherosclerosis and 80% thrombosis. So we put a drug-eluting stent to open the flow in the LED. We get the clinical benefit and the long-term benefit from opening the flow to the LED. But the drug-eluting stent that we inserted inside this patient promotes the healing of the plaque together with the high-dose statins. I think the idea of this trial was promoting the healing of the vulnerable plaque with the optimum guideline-directed medical therapy, plus putting a method to deliver the drug to this plaque using the absorbed biovascular scaffold and taking into consideration that after 3 to 4 years, this absorbed biovascular scaffold will not be there anymore, and the plaque will be already healed, and the fibrous cap will be surrounding the plaque, and the lipid core will be less. So I think this is the hypothesis that I got from this trial. Maybe to reduce the time, we can move to the final one. This is an easy one, which actually we had an idea about previously. So this is the definition 2 trial. This is a trial coming from China also, by the way, because it matches so well with the DK5, the DK Crush 5 trial for the left main. So this is a trial to compare the two stent versus the provisional stent technique, but not in left main intervention, in all complex coronary bifurcating lesions. So they do not have a universal definition for coronary bifurcation lesion complexity. So they put a definition of their own, which is the definition, as we say here. The definition criteria for complex lesion is defined as side branch length more than 10 millimeter, side branch diameter stenosis more than 70% for distal left main, or more than 90% for non-left main. And this is the major criteria, and you need 2 of the minor criteria, plus minus 2 of the following: moderate to severe calcifications, multiple lesion, bifurcation angle 45 to 70%, reference diameter of the main vessel less than 2.5, thrombus or main vessel lesion more than 25. So this is the definition. You need 1 major and 2 minor criteria. After you take 1 major and 2 minor criteria, so this one will be a Medina 111 or 011, and of course the side branch is more than 2.5 millimeters. So those patients are real life bifurcation lesions, which are mostly demanded to take 2 stent technique. They included them in the study, and as you see here, we compare between the provisional and the 2 stent technique. The primary endpoint, target lesion failure, of course, in 660 patients, 325 patients to the provisional group, and 328 patients went to the 2 stent group. The provisional group, there was a crossover of 70 patients with 2 stent technique and performed the TAP technique. The 2 stent group, they performed the DK crush in 75% of the cases and the kilot in 25% of the cases. I will show you the distribution. And the safety endpoint was stent thrombosis at 12 months. The primary endpoint was target lesion failure at 12 months. And angiographic follow-up at 13 months was performed exactly like the DK Crush 5 trial. Left main bifurcation was nearly 30% of both cases. So 28.7% in the 2 stent technique and 28.9% in the provisional group were left mains. LEDs, LCX, and RCAs were matched between them also. I would show you. LED diagonals was more than 50% in both cases. The lesion length was 21 plus minus 10 in both groups. Transradial was performed in 80% of the patient. 2 stent technique was performed in 92% here, and in 22, as I told you, 73 patients were crossed over. The DK crush, 3/4 of the cases. The other was kilot. And here, if you performed a 2 stent technique, it was TAP technique. Final kissing balloon, 95% in the 2 stent technique. And if you perform the 2 stent TAP, you would perform also 96%. And pot after final kissing balloon was performed in 90% of each group. So what I like about this trial is that this is a real life bifurcation trial. What I like more is that it matches Egypt so much. They performed IVUS in only 25% of the cases. So IVUS was not routine. 75% of the cases did not perform IVUS. The 2 stent technique was proven to be safe. As you see, the all-cause death, 2.7% versus 3.4. Cardiac death, 2.1% versus 2.5. definitive stent thrombosis 0.9%. The numbers of the patients are equal, 9, 11, 7, 8, 3, 3, p-value non-significant. So this trial demonstrates the safety of two-stent technique in complex bifurcation lesion included by the definition if you perform a final kissing balloon in 95% of the cases and a final pot after the kissing balloon in 95% of the cases. So this is the 2020 practice of bifurcation. I want to show you something before we go here. The outcomes. The primary outcome was target lesion failure at 12 months, defined as cardiac death, target vessel MI, or clinically driven target lesion failure, occurred in 6.1% of the two-stent group compared to 11.4% of the provisional stent group. So performing the two-stent strategy in the complex bifurcation lesion that mandates a two-stent strategy will lead to a better outcome than the provisional stent strategy, in which lesion? In the lesion definition, included in the definition, which is a complex bifurcation lesion, which is the lesion that mandates a two-stent strategy. So this trial actually tells you that if you have decided from the start that this vessel side branch is more than 2.5, that this vessel atheroma extends beyond 10 millimeter, that this vessel is significantly pinched or calcified or stenosed with a high plaque burden, it's better to do the two-stent strategy than performing the provisional stent strategy. The secondary outcomes, the definitive or probable stent thrombose at 12 months, 1.2 in the two-stent strategy, 2.5 in the provisional. Cardiac death was equal, 2.1 versus 2.5. Target vessel myocardial infarction, 3 versus 7.1. And clinically driven target revascularization, 2.4 in the two-stent group versus 5.5 of the provisional stent group. What the ACC, this is from the ACC I extracted, that interpreted that among the patients with a complex bifurcation lesion undergoing revascularization, a two-stent strategy was superior to provisional stent. And this is very important. We are speaking about the complex bifurcation lesion. And this complex bifurcation lesion in the flow chart by the European Bifurcation Club and by the revascularization guidelines would advise you to perform a two-stent strategy. So this trial actually tells you that when two-stent strategy is indicated, you actually get a better outcome. And this benefit was due to reduction in target vessel MI and target lesion revascularization. And if you perform the proper final kissing balloon and the final pot, you will get a numerical reduction in the definite probable stent thrombosis with the two-stent versus the provisional stent strategy. So here you can conclude that two-stent is associated with a less one-year target lesion failure for complex coronary bifurcation lesion driven by fewer target vessel MI and clinically driven target lesion revascularization. The DK crush was the most commonly used, 78% of the cases in the two-stent technique, and the tap was the bailout technique if you perform a provisional stent. Thank you.
Thank you so much, Zahran. Actually, this was the easiest trial of them all because this simulates what we are now practicing and what is logic that the trend of doing more provisional stenting in lesions or side branches that are significantly stenosed, that are large enough and important enough, proven to be not a very wise decision and we are all tending now to do it two-stent technique from the start. There is an issue that this study did not tackle clearly, but I want to have all our opinion in, is the presence of a significant ostial, very large or large enough side branch with a little bit apparently healthy or non-significant plaque in the proximal main vessel. So this is a very, very challenging situation.
By
So
speaking about the 001 bifurcation, yes.
yes,
001 bifurcation was not included in this trial.
I know. And
The
that's why I'm
001
saying that.
bifurcation is a challenging situation
And-
all the time, especially if it's an ostial circ.
And not in any trial, actually.
Yes,
Yeah.
and not in any trial.
And
I don't know
that's
if you are
why.
seeing my screen now or not. This is
Yes,
a
we're
very
seeing your
recent
screen.
editorial from the European Heart Journal. And this editorial was discussing the previous trial that I showed you, the definition trial, okay? So the authors of this editorial tried to get a nice flow chart which matches our practice. So this is the flow chart. There's a bifurcation lesion. First question, is this a relevant side branch with a diameter more than 2.5 millimeter? If the answer is no, then this is a trivial bifurcation and there is no dedicated studies to discover this condition, okay? And so they tell you, do not look at this bifurcation at all. If yes, then here you ask the question Haitham is asking. This is a true bifurcation Medina 111 or 011? If the answer is no, then this is not a true bifurcation, and there is the evidence for the benefit of provisional one-stent strategy, and there is no evidence regarding the contemporary stents and stenting techniques. If the bifurcation is 111 or 011, this is a complex true bifurcation or no. The complex true bifurcation is the one that we said in definition, according to definition score, one major and two minor criteria. If it is a complex true bifurcation, yes, then you have an evidence now for the benefit of systematic two-stent strategy. Systematic means routine. So if, according to the definition, this is a complex bifurcation, you are routinely using a two-stent technique. If the answer is no, this does not apply to the definition, then you have a non-complex true bifurcation, and here you have equivocal evidence. Possibly a minor benefit from the two-stent strategy coming from the DK5, from the DK2, and from the Nordic 4. Possible minor benefit. This is 3 trials that showed you the benefit of two-stent strategy versus provisional. The DK Crush 2, the DK Crush 5, and the Nordic Baltic 4. But against those 3 trials, you have another 100 trials that tell you that provisional stenting is better. So they say here, there is equivocal evidence. So this is a very nice flow chart that I wanted to share with you. Back to Karim and Haitham.
So
Go ahead, Karim. Go ahead.
So I think the key of success in this trial and of managing the complex bifurcation lesion, number one, as you mentioned, how to define the complex bifurcation lesion and how to identify it. And I believe the definition 2 trial made some important characteristics of this complex bifurcation lesion. And the definition, according to the definition 2 trials, can help to better classify this lesion and to determine which lesion would be treated with two-stent technique. This is number one. Number two, I think with the advancement of stent technology and the presence now of new generation stents with better platform and thinner struts, this improves the outcome of two-stent technique rather than provisional stenting in the complex bifurcation lesion, of course. Number three, and this is the most important, to have a wonderful result such as mentioned in this trial. We should we should have the clear knowledge about how to effectively do the Dickey Crush 2 trial and the other two stent technique. And the steps should be rehearsed every time, and each time you will do a bifurcation stenting to have a perfect result and to have improved outcome with the two stent technique.
Yes, I totally agree with you, Karim. Haitham, do you need to add something?
No, I think Karim said it all. And that's why I've skipped the questions to this trial, because it's more or less a logic everyday practice now. And I want to jump to the controversial question. So I think Karim said it all. If Ahmed do have a comments, Ahmed Saeed.
No, thank
Okay,
you,
I
Haitham.
think
Yeah, you have wrapped up everything. Thank you.
okay. I think we've covered it all, dear Zahran.
Okay, so thanks a lot for all of you today for joining us. I know this was a very heavy session, and I have
No,
really
thank you for preparing such a delicious meal, Zahra.
thank you, Karim. So we
Yeah,
discussed.
it's an enjoyable. It was an enjoyable session, dear Zahran, and not a heavy session.
Thanks a lot, Haitham and Karim, Ahmed and Abdurrahman. Without the teamwork and the support, it would not have been ever possible. Thanks to all of our viewers who have been joining us tonight. We discussed four, let's say, interesting trials. The prospect absorbed, which they decided to put a BVS for specific lesions which were not angiographically or IVUS significant, but included a rich lipid core and a thin fibrous cap identified by nurse. And they saw the outcome in the form of healing of this cap. The ultimate trial, the routine use of intravascular ultrasound guided PCI versus angiography guided PCI. We have the 3 years result, which is consistent with the 12-month result previously published in 2018, where IVUS actually improved the outcomes regarding the target lesion failure. The Disrupt Cat3 proved the efficacy and the safety of the intravascular lithotripsy using the shockwave device. And we described the device to you, and we knew that this device is not suitable for every case. You need to have a near complete arc of calcium, and you need to have some specific technical tips and tricks when dealing with this device. And of course, we ended this by the easiest one, which was the definition 2 trial, which confirmed the idea in the editorial that I told you previously. If you have a complex bifurcation lesion from the start that has one major and two minor criteria of the definition criteria, which is the criteria that we all know in the presence of a sizable side branch and the 111 or a 110 or a 101 actually uh, bifurcation, you are justified and actually you are advised to perform a PCI with a two-stent strategy. So I would like to thank you all for joining me tonight. Next week, inshallah, we will have a very interesting session about the new updates in the hypertrophic cardiomyopathy guidelines by the American College of Cardiology. And we will have Professor Karim Saeed and Professor Mohammed Hosni joining us from Cairo University and Aswan Heart Center. And the final Thursday in this year, we will discuss the part 2 of the coronary intervention trials, and we have two new surprises in 2021. So see you next week, and stay safe.